Hey everyone, and welcome to Evidence at the Bedside. We are your guides to medical knowledge, and if you enjoy what we do here, please take a second to like, share, and subscribe so we can keep bringing you these deep dives.
Yeah, thanks for joining us. Today, our mission is to unpack the official 2021 American College of Gastroenterology clinical guidelines on C. diff. We're, digging into the source material on prevention, diagnosis, and treatment to find out what actually works.
If you walk through the wards of really any major hospital, you are inevitably going to encounter a patient battling this microscopic ecological disaster.
Absolutely, every single day.
Right. And, we visualize a human gut as this lush, old-growth forest, right? Like a perfectly balanced, highly diverse microbiome.
Yeah, exactly.
But then you give a patient a broad-spectrum antibiotic for, say, a routine pneumonia or urinary tract infection, and you are basically sending a clear-cutting logging operation straight through that forest.
Yeah, the native flora just gets completely decimated.
It does. And sitting in the soil, just waiting for this exact moment of vulnerability, is this opportunistic, highly aggressive weed, Clostridioides difficile, or as we all refer to it at the bedside, C. diff.
And the burden of this disease is fundamentally altering our daily practice. We are looking at roughly 453,000 infections annually, just in the United States alone.
That is a staggering number.
It really is. And it results in nearly 14,000 deaths. But, the epidemiology here is experiencing this massive tectonic shift.
Right, because it used to be just a hospital issue.
Exactly. Historically, if you diagnose C. diff, you were looking at a hospital-acquired infection, like a patient who contracted it while recovering in the ICU or lingering in a long-term care facility.
But the infection control protocols have really changed that.
They have. Aggressive protocols have successfully driven those hospital-acquired cases down by about 24% over recent years.
Which is great, but it means the battlefield has completely changed for us.
100%.
We are seeing community-acquired cases just surging. They now make up anywhere from 35 to 48% of all new diagnoses.
Yeah, nearly half. It's wild.
Right. You have a perfectly healthy individual, they take a short course of clindamycin for like a dental procedure, and 2 weeks later, they are having massive debilitating diarrhea at home.
Yeah, it's no longer just a nosocomial complication. It is a primary care crisis.
Exactly. So our mission for today's deep dive is to unpack the current clinical framework for managing this crisis.
Right, to really serve as a shortcut to the latest evidence-based gastroenterology for everyone listening.
Yes. We need to dissect the diagnostic algorithms, the frontline interventions, and this big shift toward restoring the microbiome rather than just scorching it.
I love that. So the obvious starting point is the patient sitting right in front of you with acute diarrhea.
Right, and the immediate clinical reflex there is to just order a stool panel.
Naturally.
And if the lab runs a PCR and it lights up positive for C. diff, the instinct is to immediately write an order for POVANC.
Oh, all the time.
But treating based solely on a positive PCR is arguably the most common and, frankly, potentially dangerous trap in modern GI practice, isn't it?
It absolutely is.
Yeah.
Because it fundamentally misunderstands the difference between colonization and active disease.
Right.
Up to 21% of hospitalized adults are walking around right now fully colonized by C. diff.
Wait, 21%?
Yeah, 21%. The bacteria are present in their intestinal tract, but their native microbiome is robust enough to suppress it. So they're completely asymptomatic.
Ah, okay.
So if you indiscriminately prescribe powerful antibiotics to an asymptomatic carrier, just because a PCR test detected the bacteria's DNA, you are going to clear-cut their healthy flora.
And potentially trigger the exact fulminant infection you were trying to avoid.
Exactly. You're creating the vulnerability.
So we really need a clinical North Star before we even think about touching the order set.
We do. And that North Star is strict symptomology.
Right. You never send form stool to the lab, period.
Never.
To even qualify for a C. diff workup, the patient must be producing 3 or more completely unformed stools, so that's Bristol stool scale 5 to 7 within a 24-hour period.
Yes, and those symptoms must be unexplained.
Right, meaning we have properly evaluated their volume status and ruled out obvious culprits.
Like recent laxative administration or maybe a new enteral tube feeding regimen that's just upsetting their stomach.
Exactly. So the physical symptom basically acts as the gatekeeper to the 2-step diagnostic algorithm.
Right. When an unformed stool sample actually reaches the lab, step 1 requires a highly sensitive net.
So we use a GDH antigen test or a nucleic acid amplification test like a NAAT or a PCR.
Yeah. And these modalities are looking for the mere presence of the organism or its genetic material. The negative predictive value here is just exceptional.
Because if the PCR is negative, you can rule out C. diff with near certainty.
Exactly. You can pivot your differential diagnosis to other etiologies.
But a positive PCR only proves the weapon is in the room. It does not prove the weapon is being fired.
That's a great way to put it.
Right. To prove it's firing, that requires step 2, the toxin EIA or enzyme immunoassay.
Yeah, because the biology behind this is where the pathology actually happens.
C. diff causes damage by releasing 2 specific exotoxins, right? Toxin A, an enterotoxin, and toxin B, a cytotoxin.
Yeah, and the mechanism of cellular destruction here is just brutal.
Oh, it really is.
When toxins A and B enter the colonic mucosal cells, they specifically inactivate the Rho family of GTpases.
Which are the regulatory proteins responsible for maintaining the cell's structural scaffolding?
Right, so without them, the actin cytoskeleton physically collapses.
Wow.
Yeah, the epithelial cells round up, they lose their integrity, and those microscopic tight junctions holding the intestinal lining together just completely blow open.
And that's when fluid and electrolytes hemorrhage from the tissue directly into the gut lumen.
Exactly, which is the physiological driver of the profound watery diarrhea we see at the bedside.
So when the toxin EIA comes back positive, it confirms that those specific cytotoxins are actively destroying the colonic mucosa.
You got it. A positive PCR with a positive EIA is your definitive diagnosis for active CDI.
But the clinical complexity really arises in the gray area, doesn't it? Like, what about a positive PCR but a negative toxin EIA?
Yeah, that scenario demands intense clinical judgment rather than just, blind adherence to an algorithm.
Because you might just be looking at a harmless carrier whose diarrhea is secondary to an entirely different viral infection.
Right. Or you might be dealing with a false negative EIA, since those tests lack perfect sensitivity.
True. Or maybe you're catching an early active infection where the toxin concentration simply hasn't reached the laboratory's threshold of detection yet.
Exactly. You really have to synthesize the patient's entire clinical picture. Look at their white count, their fever curve, and their antibiotic history to make the call.
That makes total sense. Now, those destroyed tight junctions you mentioned lead directly into a highly controversial area of secondary prevention.
Oh, the probiotics debate.
Yes, patients are terrified of getting C. diff when prescribed antibiotics. So the immediate cultural reflex is to consume heavy doses of over-the-counter probiotics.
Yeah, it feels so intuitive to reseed the gut with good bacteria.
It really does. Like, everyone tells you to eat yogurt or take a probiotic. But looking at the robust clinical data, the consensus is actually a strong recommendation against the use of probiotics for preventing CDI.
Yeah, the mechanistic reality of probiotics directly contradicts the marketing.
How so?
Well, the human gut microbiome requires immense diversity. We're talking thousands of interacting species to maintain barrier function and immune homeostasis.
Right.
But when you ingest a commercial probiotic, you are dropping massive billions of CFU payloads of a single synthetic strain, usually a lactobacillus or a bifidobacterium.
So rather than restoring the complex native ecosystem, you are introducing an aggressive monoculture.
Exactly. It monopolizes the available nutrients and physically occupies the mucosal real estate.
This synthetic monoculture basically acts like a weed itself. It aggressively competes for resources, which effectively creates a roadblock.
Right. It impedes the patient's native, highly diverse flora from reestablishing itself after the antibiotic washout period. We're essentially hindering the natural healing of the microbiome.
And the implications go far beyond just a delayed recovery, especially for the immunocompromised patients we see on the wards.
Oh, definitely.
Because we established that C. diff toxins destroy the tight junctions of the gut lining, so that barrier is now highly permeable. When a vulnerable patient swallows a massive dose of live probiotic bacteria, those organisms can slip right through those microscopic tears in the mucosa and enter the systemic circulation.
It's terrifying. We actually have documented case reports of patients developing severe bacteremia and fungemia, where the blood cultures grew the exact strains sequenced from their daily probiotic supplement.
Wow. So the it can't hurt mentality is just scientifically false.
Completely false. And evaluating risk brings up another pervasive medication dilemma: the use of proton pump inhibitors, or PPIs.
Oh, right. Because we know that gastric acid acts as a primary chemical defense mechanism against ingested pathogens.
Exactly. Suppressing that acid logically allows C. diff spores to survive gastric transit and reach the lower intestine.
So the observational data clearly associates PPI use with an elevated risk of C. diff.
It does.
Despite that clear association, we don't automatically discontinue a patient's pantoprazole or omeprazole when they are diagnosed with C. diff.
No, we don't. We have to weigh competing morbidities.
Right.
If a patient is on a PPI for a documented severe indication like a recently bleeding gastric ulcer or severe erosive esophagitis or Barrett's esophagus, the immediate life-threatening risk of a massive upper GI bleed far outweighs the marginal increased risk of exacerbating the C. diff.
So we maintain the PPI and focus our efforts on targeting the lower GI pathology.
Exact.
Which brings us to the actual pharmacotherapy. For years, intravenous and oral metronidazole was the default reflex for a mild to moderate infection.
Yeah, but that era is effectively over.
Why is that?
The data just shows unacceptably high clinical failure rates, lower sustained cure rates, and honestly, a real risk of cumulative neurotoxicity with repeated use.
So for an initial non-severe episode, our frontline weapons are now PO-VANC and fidaxomicin.
Yes. And looking closely at the grade methodology, the grading of recommendations, assessment, development, and evaluation framework there is a fascinating anomaly regarding oral vancomycin.
Oh, I know exactly what you're going to say. The recommendation to use PO-VANC is classified as strong, yet the supporting evidence is explicitly graded as low quality.
Yeah.
I mean, to someone outside the clinical space, prioritizing a treatment based on low-quality evidence sounds like malpractice.
It really does sound bad, doesn't it? But it reflects the practical reality of evidence-based medicine at the bedside.
Right, because low quality in the strict grade taxonomy simply means there is a lack of pristine, modern, double-blind, randomized, placebo-controlled trials.
Exactly. Vancomycin is a legacy drug. Its efficacy in treating CDI has been observed and documented over decades of clinical practice.
It would be fundamentally unethical today to design a trial where half of the symptomatic C. diff patients receive a placebo just to satisfy a modern statistical scoring rubric.
100%. The bedside efficacy is so undeniable that the risk-benefit ratio heavily favors a strong recommendation, regardless of the historical trial architecture.
Makes perfect sense. So vancomycin is traditionally dosed at 125 milligrams PO 4 times a day for 10 days. But fidaxomicin is rapidly becoming the preferred agent, and it all comes back to the ecological damage we discussed earlier.
Yeah, oral vancomycin is effective, but it basically operates like a broad-spectrum explosive.
Right. It kills the C. diff, but it also blasts a massive crater into the recovering native flora.
Exactly. Fidaxomicin, conversely, acts like a sniper rifle.
Because of its pharmacology. It's a macrocyclic antibiotic that inhibits the bacterial RNA polymerase, but it is remarkably narrow spectrum.
It is. It specifically targets Clostridioides species while largely sparing the Bacteroidetes and Firmicutes phyla.
And those two phyla act as the foundational pillars of a healthy gut ecosystem.
Yes. By preserving the structural integrity of the native microbiome, fidaxomicin leaves a competitive environment intact.
Which drastically reduces the chances of the C. diff spores vegetating and causing a relapse a month later.
Exactly. And recurrence is the true nightmare of this disease.
It really is. But acute escalation is the immediate threat. We have to identify the exact moment an infection transitions from routine to severe.
Before we jump into those severe markers, I just want to quickly remind everyone listening to like, share, and subscribe to Evidence at the Bedside. We want to make sure you never miss a high-yield breakdown like this one.
Absolutely. So talking about those objective systemic markers for severe disease, a white count spiking over 15,000 indicates a massive systemic inflammatory response.
Right. And a serum creatinine level rising over 1.5 signals that the profound volume depletion and toxin load are actively shutting down the kidneys.
So when a patient crosses those thresholds, we escalate to fulminant CDI, representing a life-threatening systemic crisis.
Yeah, the patient may present with severe hypotension, shock, or the most dreaded complication, toxic megacolon.
The physiology of toxic megacolon is terrifying.
It really is.
The inflammatory cascade triggered by the toxins penetrates deep through the mucosal layers and attacks the myenteric plexus, right? The neural network embedded in the bowel wall that controls peristalsis.
Yeah. The colonic smooth muscle becomes completely paralyzed.
And nitric oxide floods the tissue, exacerbating the relaxation. Stool and colonic gas have nowhere to go, causing the large intestine to rapidly dilate like an overinflated balloon.
And as it does, the bowel wall thins out, ischemia sets in, and without immediate intervention, it will perforate,
Spilling highly toxic fecal matter directly into the sterile peritoneal cavity.
Exactly. So in a fulminant scenario with an ileus or toxic megacolon, narrow spectrum nuances are completely abandoned.
We deploy maximum medical therapy. PO-vanc pushed to 500 milligrams every 6 hours.
Right. And because the paralyzed gut may prevent the oral vancomycin from reaching the distal colon, we simultaneously administer VV flagyl.
To attack the inflamed colonic tissue from the systemic capillary beds.
Exactly.
Now, if that maximum pharmacotherapy fails to stabilize the patient within 48 to 72 hours, the historical last resort was surgical, a total colectomy.
Yeah, we would literally excise the patient's entire large intestine, leaving them with a permanent ileostomy,
Right.
just to prevent sepsis and death.
The morbidity and long-term quality of life destruction associated with a colectomy are devastating.
They are, and this is exactly why the utilization of fecal microbiota transplantation, or FMT, represents a watershed paradigm shift in modern gastroenterology.
Okay, let's unpack this, because we are literally talking about taking feces from a healthy donor and putting it into a critically ill patient.
We are. For patients suffering from multiply recurrent C. diff or severe refractory disease, we no longer rely solely on trying to chemically poison the pathogen.
Right.
We introduce a complete, mature, healthy microbial ecosystem from a rigorously screened donor directly into the patient's GI tract.
And the mechanism of action for FMT goes far beyond simple physical crowding. It involves complex metabolic restoration, specifically regarding bile acid metabolism.
Yeah, this part is fascinating.
In a healthy gut, the native flora breaks down primary bile acids synthesized by the liver into secondary bile acids, and these secondary bile acids act as direct, potent inhibitors of C. diff vegetative growth.
Exactly. But a microbiome decimated by repeated rounds of vancomycin loses the specific bacterial species required to perform that conversion.
So the gut just fills with primary bile acids.
Right, which actually triggers C. diff spores to germinate.
Oh, wow.
Yeah. FMT rapidly reestablishes that critical metabolic pathway. The transplanted flora begins converting bile acids again, and the resulting secondary bile acids biochemically suppress the C. diff.
Basically starving it out of the ecosystem.
Exactly. And the clinical trial data demonstrates astonishing 84 to 92% cure rates for multiply recurrent CDI.
That's incredible, but delivering that ecosystem safely is the final logistical hurdle. The traditional gold standard is delivery via colonoscopy, right?
It is. It allows the gastroenterologist to deposit the donor material directly throughout the entire colon while visually inspecting the mucosa.
Looking for those classic yellow raised pseudomembranes that characterize severe C. diff colitis.
Right. However, recent cohorts demonstrate that non-invasive methods are matching that efficacy.
You mean the encapsulated, freeze-dried donor microbiota?
Exactly. Swallowing frozen oral capsules has proven completely non-inferior to colonoscopy. It achieves identical cure rates while entirely sparing the critically ill patient the risks of procedural sedation and bowel perforation.
That's a massive win. All right, let's synthesize everything we've discussed into our rapid-fire summary. You ready? What is the absolute bottom line for the clinicians listening?
Let's do it. First, the primary diagnostic tool is the two-step algorithm, governed strictly by the Bristol stool scale. Never test formed stool.
Right. Use the highly sensitive GDH or PCR to cast the net and mandate the highly specific Toxin EIA to confirm active mucosal destroying disease.
Second, the most common red herring to avoid is asymptomatic colonization.
A positive PCR in a patient without clinically significant unformed diarrhea is a colonized carrier. Do not treat a PCR test. Treat the patient.
Third, the definitive first-line intervention for an initial non-severe episode is oral vancomycin, or, ideally, the narrow-spectrum macrocyclic fidaxomicin,
to preserve the remaining native microbiome and prevent recurrence. Finally, the hard stop. Discontinue the use of commercial probiotics for secondary CDI prevention.
Yes, they impede natural flora recovery and carry a documented risk of systemic translocation and bacteremia in vulnerable populations.
Yeah, what are the 3 definitive pearls to take to the bedside tomorrow morning?
Pearl number 1. The physical symptom dictates the lab test. If the stool takes the shape of the container, cancel the C. diff order.
Love that.
Pearl number 2. Trust the toxin EIA over the PCR when determining if an infection is actively driving the pathology.
On pearl number 3.
When a patient presents with their 3rd or 4th recurrence, stop cycling the same toxic antibiotics and start evaluating them for a microbiome-restoring FMT.
Excellent. You know, as we look beyond FMT, the horizon of C. diff management is revealing even more targeted therapies.
Oh, definitely.
The guidelines point toward novel agents like bezlotoxumab, and this isn't an antibiotic at all. It's a synthetic monoclonal antibody delivered intravenously. It circulates in the bloodstream and specifically binds to and neutralizes toxin B. So it completely disarms the pathogen's primary weapon without harming a single native microbe in the gut.
It's amazing. Therapies like bezlotoxumab and encapsulated FMT really signify a profound philosophical departure from 20th century medicine.
We are officially exiting the scorched earth era of broad-spectrum antibiotics. The future of treating complex infectious diseases doesn't rely on inventing increasingly toxic poisons to carpet bomb the invaders.
No, it doesn't.
It relies on meticulously engineering, supporting, and reinforcing our internal ecosystems so that the pathogens simply cannot survive the competition.
Nurture the forest and you won't have to fight the weeds.